I'm going to talk about an area of neurology that actually I find extremely interesting, and that is seizures. There are neurologists who actually specialize in epilepsy. We call them epileptologists, just like there are MSologists, which we are. But there is intersection between these diseases. Okay, and so in our MS center, if you happen to have MS, but you also have migraine, we're going to treat it. If you happen to have MS and you also have epilepsy, we are going to treat it. So once again, our approach is comprehensive care. We want to treat the whole person and everything that this disease might bring. And so it turns out that seizures themselves have an increased frequency of occurring in MS. Okay? And seizures, of course, are a very frightening entity to many people because they can come with loss of consciousness, which is a devastating event for anyone. And so I thought it really behooves us this morning to talk about how often does this really occur? Is it preventable? Is it treatable? And then finally, in what settings do we see it? Okay? And what I'm hoping is not only will you gather some information if you already have a seizure disorder, but more important, be able to recognize this when it comes up. I'll just, before I even get into the talk, tell you that there are a lot of different MS symptoms that mimic seizure. And so there are patients who come in who think they are having seizures and are not, and are having other MS-related symptoms. There are types of events that can occur at the beginning of MS that are mistaken for seizures. And I have had many MS patients who had what we call tonic spasms of MS, where all of a sudden they began to have spells of a hand pulling up or of something running down one side, and the very first neurologist who addressed it thought that they were having some form of seizure. And it isn't until later that they're discovered to in fact have MS. That's called tonic spasms of MS, and tonic spasms of MS is in fact not seizures. Okay, so let me launch into what we know about seizures in MS. Seizures itself, epilepsy, is a huge topic, and so I'm going to try to stay focused and give you a few definitions, but then really talk about the occurrence of seizures in MS and give you a couple of cases that represent examples of that. So how do we define a seizure? A seizure is an episode, okay? It's a paroxysmal, meaning sudden onset, sudden offset episode, okay? So seizures is not a symptom you get that lasts 2 hours or 3 days like your migraine. That's not a seizure, okay? It has to be brief. And how brief? Seizures generally last seconds to minutes. Now, you can have a seizure, come out of a seizure, be recovering, we call that the post-ictal, the post-seizure phase, and go right back into another, and sometimes that can be confusing, particularly if your seizures are focal, which means they create an experience or a behavior that is not very obviously seizure. So when somebody falls to the ground and convulses and shakes all over, I think nobody has trouble recognizing that. But if your seizure is actually a funny smell, and you keep getting this smell of smoke, and it lasts 45 seconds, and then 3 hours later you get it again, and you keep saying to people around you, "Are you smelling the smoke that I'm smelling?" And they go, then you know you're having an experience which nobody else is. And the thing about seizures is that they are recurrent and they are stereotypic. What do we mean by stereotypy in seizures? It means it's the same thing every time. Why? Because it's coming from the same area of the brain every time. You don't get seizures that first begin in this spot, and then the next day they're beginning in this spot, and then this spot, and giving you something different each time. When we see people like that, we have a different word for that, okay? It's not a nice word, you know, it's behavioral or crazy or something like that. So seizures are not migratory. They don't go to different places in the brain and give you a new symptom each time. It's one area of the brain that is irritable, that is discharging in an abnormal way, and that is generating some sort of experience. And what is that experience? It could be the bad smell I just talked about. It could be a feeling of, I've been here before. What do we call that? Déjà vu. That comes oftentimes from the temporal lobe. That's where we get déjà vu seizures from. It could be a motor seizure that's just a twitch. Your hand's twitching and it goes on for 10, 15 seconds and then it stops. But then when it happens again 3 days later or 3 weeks later, same thing. So seizures are episodic, they are paroxysmal, they last a brief period of time, they are the same thing each time, and they result in possibly a behavior. There are people who have seizures in which they just space off and pull at their, I better not pull at the mic, pull at their clothes or touch their face or repeatedly smack their lips or move their tongue, and that's a seizure. Okay, so seizures can be a behavior or they can be an experience. Okay, I had one patient who repeatedly was having this experience that she would get a hallucination in which she was suddenly back in her grandma's house. She'd be standing there and all of a sudden she felt like she was there again from her childhood. And it looked just like, and it was a pleasant experience. And she had this repeatedly over a number of weeks. And then one fine day, she had that experience and then fell on the floor and began shaking all over. So the experience was a focal seizure. It was coming out of her brain. It was a complex visual hallucination, if you will, but it was the same thing every time. And then when the discharge spread over the whole brain, then she had what we call a grand mal seizure. So when the whole brain erupts with the seizure, that's when you get what people describe as a convulsion, shaking all over or stiffening, biting the tongue, frothing at the mouth, which is just hypersalivation because of the brain discharging, okay? By the way, people do not swallow their tongues in seizures, okay? They bite them because they grip with they spasm in the jaw. That often bites the tongue at the beginning. They turn blue because there's spasm in the larynx, in the vocal cords, and this is just with grand mal, not with small seizures, just with big seizures. And so for the 30 seconds or 45 seconds of the seizure, they're not moving air well. And then when the seizure's over, there's this big gasp, and the patient begins to breathe normally, but there's all this blood or saliva in the mouth. And so really, when somebody has a big seizure, what do? Turn them on their side, make sure nothing's hitting their head, and let everything run out of the mouth, especially at the end of the seizure, so when they take that first deep breath, they're not getting it all in the lungs. Okay? Just a little first aid kind of information for you. So seizures can occur whenever the brain is affected. Seizures come from the brain. They don't come from the spinal cord. They generally don't come from the brain stem or the cerebellum. They come from gray matter in the brain, from the cortical part of your brain. And seizures can come from the frontal lobe, they can come from the temporal lobe, they can come from the back, the occipital lobe, and depending on where the seizure originates, that colors what that stereotypical experience might be. But here's a whole list of different diseases, and this is a short list. I could have made a much longer list. Anything that affects the brain in an abnormal way can in fact be a generator of epilepsy, of seizure disorder. So we see people who get meningitis, and one of the symptoms of the acute meningitis is they seize. They also have a headache, they also feel sick, but they can seize. Encephalitis is more commonly associated with seizures because encephalitis means the infection is in the brain tissue itself. Meningitis, the infection's around the brain. An abscess is like a pus pocket in the brain. So it means some bacteria have gone through your blood, settled in the brain, and begin to reproduce, and then you get this almost like a tumor of infection in the brain. And any of those situations can cause seizure. Brain malformation is something we're going to see as a congenital cause of seizure, and there are many of those related to genetic diseases, to birth injury or intrauterine developmental kinds of things where the brain does not grow properly, and one of the accompaniments can be seizure. Trauma. There are different kinds of seizures with trauma. People can have seizure right at the time they hit their head. That's called a contact fit. So if you're in a car accident and you happen to slam into the windshield and you're discovered by the police to be in the middle of a seizure, that would be a contact fit, or might be. The other possibility is you had a car accident because you began to have a seizure. And that's always something we have to sort out at the site of trauma. But there also are forms of epilepsy that are post-traumatic, delayed forms of epilepsy. So you have trauma to your brain, and then 6 months, 12 months, 18 months later, after you're all healed, and you may be even healed to normalcy, where you had a concussion or you had a contusion, you had a really bad fall out of your wheelchair, you banged your head, you had a little bleeding in your frontal lobe, then you were fine, you got all over it, 18 months later, you have your first seizure. That's called post-traumatic epilepsy, and that's pretty common. Stroke can do the very same thing. So you have a stroke, and then at a delayed interval, you begin to have seizures from that area. Why is that? Because as the brain heals, the scar puts a little traction or pull, perhaps, on adjacent normal brain. You don't get seizures out of dead brain. You get seizures out of live brain, but it's brain that's become irritable. And so what happens is you begin to have a discharge in an area of the brain that's abnormal, and it's repetitive in a way that should not happen, okay? There's an interesting phenomenon that many people who have epilepsy more commonly have their epilepsy when they're sleeping or when they first wake up from sleep. What's the reason for that? The reason for that is sleep itself synchronizes brain activity. It's different. When you're awake, you've got things firing in different directions all the time. When you're asleep, there's some sort of joint synchronous discharge of neurons. That's part of normal sleep patterns, okay? But that lends itself to allowing the epileptic focus to begin its repetitive discharge. And so a lot of people will have their seizures during sleep or when they first wake up in the morning because they're a little sleepy and they haven't fully awakened that brain. Inflammation of any kind can cause seizures. So we see inflammation not just in MS, but in other autoimmune diseases of the brain. Lupus can cause cerebritis, inflammation of the blood vessels of the brain. We see seizures in lupus that goes to the brain, and many, many others. And then finally, MS. MS, in fact, in a small number of individuals, will predispose them to developing seizures. So let's look at that. Why does it occur? Well, more and more, we're getting data from pathologic studies that tell us that there isn't just demyelination in the white matter of the brain, but there is demyelination and inflammation in the gray matter. What do we mean by that? The gray matter is the superficial part of the cortex where the actual neurons are, right? Below that are the millions of fibers that are going down to the spinal cord. We call that the white matter. Why? Because to the naked eye, if you look at a brain in the pathology lab, the surface is gray. Deeper to that, it looks whiter. What makes it look white? The myelin, the covering of all those fibers. In general, you need neurons to generate seizure. So you need to generate seizure from gray matter. And there are gray matter structures deep in the brain too. We call them gray matter nuclei. But the biggest part of the gray matter is on the surface of the brain. And when we do MRIs in MS, we don't see the plaques in the gray matter. We see plaques deep in the brain, best in the white matter. And for a long time, that made us think that that was the only area involved. But recent pathology studies have confirmed that, in fact, many, if not most patients, at least have some inflammation and demyelination right in the gray matter of the brain. And it may be that those areas are more prone to being epileptogenic, meaning generating seizure, okay? The other possibility that some people surmise or talk about in the literature is that when you have an acute MS plaque, a new one, an active one, there's a lot of water that goes into that area. We call it edema. And the edema causes swelling. And that itself may be irritating to surrounding brain and may generate seizure. But most of the time in MS, if people begin to develop a seizure disorder, it's for the long term. So we think usually that it's a scar that has already finished healing and that now is generating an area of irritation in normal brain around it. A lot of this is still theory. We don't know, and it's different for different patients. So how common is this, and when do they occur? So 3 to 4% of people with MS actually experience seizures at one time or another. Now that doesn't mean 3 to 4% have long-standing seizure disorder. So that's sort of an overall percent of over the duration of the disease, what percentage of people may experience a seizure along the way. It turns out the risk of having epilepsy, a seizure disorder, and people hate the word epilepsy, but it's synonymous with seizure disorder. It doesn't mean you have bad brain or mental handicap or cognitive impairment. Epilepsy is the technical scientific name for a seizure disorder. So the risk of having epilepsy in MS is threefold higher than the general population. And seizures are common in the general population. I think it's estimated 1 in 1,000 people have some sort of seizure problem. On average, and this is average, and the range is much greater than this, but in the various small studies of seizures in MS, the average seems to be about 6 to 7 years of disease, of MS disease, is when people begin to have seizure disorder, okay? But there are people who in fact have seizures as their first manifestation of MS. And I just told you about a confusing issue, which is tonic spasms, these funny episodic things of a sensation going down your side or a hand pulling up that look like seizures but are not seizures. That can happen in MS. But people can in fact begin their MS with a seizure disorder, presumably because they've been making some lesions in their brain, some plaques, for a period of time before they ever actually have a first symptom. So, importantly, MS severity, how bad your MS is from other standpoints, how much disability you may have, how many areas of involvement you may have, how many lesions on scan you may have, is not causative specifically or associated specifically with your MS. So you can have very mild MS, and I have a number of patients who actually have zero disability from their MS. They've had MS 10, 15, 20 years, but they have a very active seizure disorder. So there isn't a strong correlation. You think about it, if one little scar can generate a seizure disorder, you don't have to have 35 scars or advanced disability to have seizures in MS. What are these seizure types that people experience? And I've already sort of described for you what a grand mal is. In people with inherited epilepsy, my father had seizures, my uncle has seizures, and I have seizures, we all have grand mal. That's referred to as primary generalized seizure disorder. And that is a genetic form of epilepsy. That's not what we see in MS, okay? What we usually see in MS are people who are having what are called focal seizures or partial seizures. That is, seizures that are creating this repetitive one experience. Twitching of the face, twitching of the hand, funny smell, visual hallucination, odd behavior, spacing off. That's a focal seizure. It really means that it's beginning in one area of the brain and recruiting the neighborhood neurons just in that area to create this behavior or experience. So we call that focal seizure. Now, if my focal seizure is just my thumb twitching and I stay awake for the whole thing and then it stops and I tell the doctor exactly what happened, then my consciousness is not involved. We call that a simple partial seizure. It's focal and it's simple. It does not alter consciousness. But if my seizure, in fact, is I space off. I get a deja vu feeling and then I'm gone, and my family reports that I stare and won't answer them for 20 or 30 seconds, and then I'm back again. That's called a complex seizure. There is an alteration in awareness or consciousness, okay? Interestingly, people can have partial complex seizures and continue to do complicated things. Like, there's a partial seizure where somebody, every time she gets it, she goes over to the nearest box or her purse and she starts emptying things out. Her coordination is perfectly intact. Then she starts putting everything back in. Then she starts taking it out. She has no recollection of doing these things, okay? We also have patients who have a partial seizure that's complex, and if they happen while they're driving their car, they keep driving, but they're not actually conscious. Not a good thing, right? That's why we tell people with seizures that aren't controlled that they can't drive. I had a patient who had that. She got off her exit, proceeded into a parking lot, and grazed 7 cars before her car came to a stop, okay? And then when she came to, she couldn't understand why there were 1 million people around her car pounding on the windows, right? So that's a partial complex seizure. If that partial seizure in fact spreads to the whole brain and erupts the whole brain, then you have a grand mal. And unfortunately, sometimes patients present with a grand mal and they have no recollection of a partial onset. They don't remember the bad smell before they lost consciousness because it's instantaneous, okay? And because a grand mal wipes out your memory for the couple hours before. But in general, we feel that people with MS who have seizures usually are starting focally, and if they have a grand mal, it's because that seizure then spread to the whole brain. And when we medicate for seizures, our objective is to not only obviously prevent grand mal, but to prevent the focal seizure, because we don't want there to be any possibility of spread to either a complex seizure where people lose awareness or a grand mal where they can be injured. Okay, so that's a little bit on categorization of epilepsy. How do we diagnose somebody's seizures? Number one here is the history, the history, the history. That's our best way of knowing if something is a seizure. When patients describe to me it's the same thing again and again, I get that stereotypic. How long does it last? 30 seconds. How many in a day? Well, I can have 1 and then not have it for 3 weeks, then have 3 in a day, then not have it for 6 months. That's typical for seizures. Okay, it's not all day long. So the history is key. If the patient can't give me the details I need the eyewitness. Who's seen this? You know, your spouse, your partner, your friend, your kid. I need to talk to them and get a description, because it's the description oftentimes that nails the diagnosis. Why? Because the EEG is not all that helpful. If you do a brain wave test in EEG between seizures, you may see absolutely nothing. It's normal. Now, if you're lucky enough to get the EEG on the head while a patient's having a seizure, you're going to see the seizure on the EEG. But the reason we do EEGs anyway is between seizures, when the patient comes in and we're trying to make a diagnosis, we can sometimes see an abnormal discharge. We call it a spike or a paroxysmal discharge coming from the area that in fact generates the seizure. So sometimes we get lucky and the EEG gives us confirmation, but a normal EEG does not rule it out. Now, if somebody's having lots of these every day, every other day, I can put them in the hospital and do what's called continuous EEG monitoring, put the electrodes on their head. It's a real fun time, you know? You get to lay in bed watching really bad TV, or worse, politics, and you've got the electrodes on your head and you're waiting to have a seizure, okay? And you know, by and large, seizures tend to be more frequent when people are under their normal stress, when they're going to work, when they're sleep deprived, when they haven't really, you know, taken their medicines on time. Seizures tend to occur out in the real world, and then when you get people in the hospital and you monitor them, sometimes they go away. But I will, people who have refractory, resistant seizures that we can't get under control, then as I said before, there are epilepsy specialists, and I will send my patient to an epileptologist because they can do even more sophisticated monitoring if they need to get a diagnosis. There are ways to implant electrodes either in the scalp or beneath the scalp to actually get closer to the seizure focus and to try to get an answer, okay? And it's important. It's very important because, as I said, there are things in MS that mimic seizures. There are also things in psychiatric illness, we call them non-epileptic seizures. Some people will have repetitive episodes of blackout or repetitive episodes of twitching that in fact are not epileptic but based on psychic stress. And I don't mean that they're faking it. These are actually generated at a subconscious level but not by epileptic discharges. So they get treated very differently. That's called non-epileptic seizures. The MRI sometimes is helpful. If you see a new active lesion in somebody who's just had a first seizure, you might be able to attribute it. But the MRI in general in MS is going to look like MS and usually does not give you an answer. However, importantly, if a patient comes in and has never had seizure and they've had MS and you have old scans, you most certainly want to get a new scan because you want to be sure there's no other new non-MS pathology. So I have MS patients who've had trauma or stroke, or they have a meningioma, a benign tumor growing on the surface of their brain. We always want to do an MRI for a complete evaluation of anybody who has seizures. Then there's the unique thing in MS that can cause seizures, which is some of our medications that we use to treat MS or MS symptoms, in fact, raise the risk of seizures. And what do I mean by that? Well, interferons in the original beta-seron and Avonex trials, there was a slight increase in risk of seizures in the patients who were on those drugs versus the patients who were on placebo. So forever after, seizures have been listed in the interferon product inserts as being a slightly increased risk with interferons. We don't know the mechanism of that. It's not common, but we believe there is an association. Patients who have baclofen pumps, where baclofen is instilled directly into their spinal fluid, have a slightly increased risk of seizure from that. We use baclofen pumps only very occasionally MS for people with particularly bad tone in their legs that interferes either with their walking or with their transfers or management. And intrathecal baclofen gets rid of the I'm dead in the head from taking baclofen pills. So we do like baclofen pumps for a subset of our patients, but that does also carry a slight risk of seizure. So does withdrawal. So if somebody has a pump and they neglect to have their pump filled and they have a sudden falling off of their pump infusion, that in itself can be irritative to the brain. We use something called Ampura, which is dalfampridine, as the walking pill, and there's an older form that's a compounded version for aminopyridine. Both of those agents have been clearly associated with a slight increased risk of seizure, particularly in patients who do not have normal kidney function, because you need your kidney function to clear the drug, and you can become toxic on the drug if you don't have good normal urine production and kidney function. So that has a very slight risk with it of seizure. And then a lot of the antidepressants, I mentioned only one here, but there are multiple antidepressants or sedatives or antipsychotics, things that we use for mental and emotional illness that's accompanying MS. And Mary Kay will be talking a lot about that. But some of those, in fact, have a slightly increased risk of seizure. And I always will hold a drug responsible if before the drug there was no history of seizures, the patient started the drug and boom, within a month, they're having their first seizure. So it's important to always look at the list of medicines, what's changed, and then check labs to make sure kidney function, liver function, to make sure it's not a problem with clearance of the medication. How do we treat epilepsy in MS? We treat it like epilepsy, like we would treat it in anybody else who happens to have a seizure disorder. The standard drugs, and I won't go through them all now, are very effective. Monotherapy is preferred. We like to get you on one drug, we can get you controlled with one drug, we don't like adding one anti-epileptic on top of another because then you're adding side effect. The medication is based on the seizure type. So there are certain medicines that are better for partial focal seizures. There are certain medicines that are better for grand mal. Some medicines cover both bases. So we use that information to select a medication. And then, of course, in the setting of MS, we have to look very closely on what are the adverse effects of that medicine. So people with MS have a lot of other medicines on board, possibly. What are we going to do to them if we layer this medicine on top of that? Okay? People with MS sometimes have cognitive issues. All of our anticonvulsant medicines tend to have cognitive impact, either make thinking a little less sharp or make people a little more tired or a little less focused. I'll go back to Amy's talk. Topiramate is a great, great, great migraine drug. It happens to be also an anti-seizure medicine. It happens also in a small percentage of people to make you brain dead, okay? I mean, just stupefy you. And we call it topiramate dumb. And people who get that, they know it almost immediately. So we do not want to use a medication that's going to alter your quality of life and your overall function for the benefit of controlling the seizures. But we certainly want to control the seizures. What's the prognosis if you happen to also have epilepsy and MS? In most cases, seizure control is obtainable. In most individuals, we can get them controlled and seizure-free. Now that's also based on compliance. So I've had lots of patients who over years, I could never get seizure-free, but every time we investigated, and you know, we're sneaky, we can get blood levels of these drugs. So we know if somebody's not taking their drug at all, okay, or taking it in below recommended doses. And just because you have small seizures doesn't mean a small dose works. It doesn't work like that. So I've had patients who were stable on their seizure medicine for a decade. And then they said, you know, I hardly have seizures. I haven't had seizures in 5 years. And they were very small when they have them. I don't need a full dose. I bet I could do with half dose. And they go to half dose. And then, you know, they get cocky. And they go to a quarter dose and then they have a seizure. Okay? When people have seizures that alter, well, any kind of seizures, we take them off the road for 6 months. That's Missouri law. That's what's recommended. That really messes up your life. Okay, when you can't drive for 6 months, can't get to work, can't get to the store, you go crazy, stir crazy in the house. We don't want to have to do that, but we have to because I described for you what happens with a partial complex seizure hitting 7 cars as she came off the road. There is sometimes spontaneous resolution, but it's hard to know when that is. And people with MS and seizures don't grow out of seizures, okay? Adult onset epilepsy. Adult onset epilepsy, we usually regard as a long-term disorder. You know, once you've had more than one seizure, you've bought the medicine. You're getting a medicine, okay? And if we take you off the medicine to see if your seizures have resolved, we also have to take you off the road for 6 months. Because in general, if you're going to have recurrence, it's usually going to be in the first 6 months. Now, that's not a total hard and fast rule. I had a gentleman many, many years ago, not MS. He had a grand mal seizure, came in the hospital. His EEG was a little bit of slowing that just looked like the aftermath of the seizure. He told me he'd been out with friends the night before and had a little too much to drink. So we decided maybe this was just alcohol related. There's something called a rum fit, an alcohol withdrawal seizure that you can get within the first 24 hours of coming off a binge, right? So he swore he wasn't going to drink, and we didn't give him a medicine, and he went 6 months, didn't have a drink, didn't have a medicine, didn't have a seizure. At 6 months and 2 days, he had 2 grand mal seizures. No alcohol. He has a seizure disorder. He's been on medicine ever since. That was hard for us to find it that way. Fortunately, he was not behind the wheel. So these are not absolute rules, but they're guidance, okay? We take people off the road because usually if it's going to recur within 6 months. It is very rare to have status epilepticus if you have a seizure disorder with MS, but it is not impossible. What we mean by status is what I was describing earlier. You have a seizure, whether it's a partial one or a grand mal, you're starting to come out of it, you're still a little dingy, a little confused, you go right back into it. You have another one. 5 minutes after that, you're beginning to wake up, nope, you go right back into it. People who have continuous or near continuous seizures for 30 or more minutes can begin to injure brain. So it's a very significant, dangerous situation. We always tell patients and their families, if you're having more than one seizure, you call 911, okay? If it's a single seizure and the patient is waking up and it's typical of their seizure disorder, and maybe you know you missed your medicine last night, so you give them some more medicine, then you call the doctor. That's okay. But status epilepticus is a neurologic emergency. You get the paramedics in. So here are my two cases, two very different cases that I want to tell you about. So this one is about deja vu all over again, okay? So a 35-year-old woman presents to the emergency room after losing consciousness in the shower that morning. She says that she's been having this odd feeling of deja vu repeatedly over the last several weeks, often occurring right after she wakes up in the morning. Her neurologic exam at this point is normal. Her tongue is bruised, not lacerated, not cut, but bruised, and she has tenderness over her head and back. An EEG is obtained emergently in the ER, and all it shows is generalized slowing over both sides of her brain. An MRI brain scan, and this is her first scan, is obtained, and it shows multiple areas of T2 signal abnormality, that's white spots, in periventricular, around the fluid spaces, white matter, and a few of them a little further out at what we call juxtacortical locations, right next to the gray matter, right at the junction between white and gray matter. What happened to this patient in the shower? Okay, she came to the ER on her own. She said, I woke up in the shower. I blacked out in the shower. What happened to her? Seizure. She had a seizure. What kind of seizure? She had a grand mal. Why do we know she had a grand mal? And again, it's based on the history in the exam. Why do we know she had a grand mal? She bit her tongue. How else? She was unconscious. I hear it. You guys are great. And she's bruised. Her head hurts. Her back hurts. Why? Because she hit the floor and she pounded on the floor. She was alone. She woke up. Oftentimes people wake up if they're alone from a grand mal and they don't really know what happened. They know they've lost time. Sometimes they put it together. Sometimes the shower curtain was pulled off the tub, or they realize if they bit there's blood trailing, and they don't remember trailing the blood as they walked into their living room, and it took them another half hour to kind of come to, and then they go, what the heck? I'm hurt, there's blood trailing, what happened to me? And they go to the ER. Okay, that's what happened to her. Okay, so was this just a grand mal, or was this a focal seizure? Well, it became a grand mal. Did it start focally? Is there any hint there that it started as a partial seizure that went to grand mal? The deja vu. That's the hint. Now, if we ask her, do you remember having deja vu in the shower right before this? She doesn't remember that because the actual grand mal wiped out, made her amnesia for the period of time right before it. She also has amnesia for some of the time after it. People with a grand mal often have retrograde and anterograde amnesia for the period of time around their seizure. They can't really reconstruct. They don't even remember what they did. They found themselves sitting on the couch in the living room with a trail of blood. They don't remember walking to the couch. They don't remember what happened. They don't remember the partial seizure that this started with. That's very typical. And it happened in the morning, in the shower, in the morning, when she's still a little sleepy. So all of these pieces put together help us. What does the EEG tell me? The EEG slowing all over. I'll tell you, it means she's post-ictal. So what we see is half an hour later, it'll be normal. It's very useful to get an EEG as close to the event as you can because it'll give you hints, okay? In MS, in most diseases that people have seizures, if you get, like I said, if you get an EEG between events, it's normal. This EEG was not normal. It didn't show the focal area of discharge. It didn't show the spike, is what we call it, of where the seizure came from, but it shows that something happened to her brain because the waves are slow all over. That's called a post-ictal phenomenon, okay? And this was her first MRI scan. So what does the MRI scan tell us? She has MS. Did she know she had MS? No. So she presents with new onset seizure as the first symptom of her multiple sclerosis. Okay? So she gets two kinds of bad news in one day. That's rough. Okay? But the seizures are treatable, and now she's going to get treated for her MS, and it's a good thing because maybe it would have taken 3 more years or 2 more years for her to have a typical MS attack. Meanwhile, she's accumulating lesions, right? So we sometimes see that now where people are brought to the ER for one thing and get a scan, and we discover that they have MS. So the next steps for this patient are to treat her seizures, to finish diagnostic workup for MS, to treat her MS, and she should be good to go. She has a normal neurologic examination, so it's good, and she should do well. Her prognosis is very good. One more. So we know that MS causes bladder problems, and we know seizures are a brain problem, so how is it that we put them together? And this is a very, and I'm going to emphasize, this is a very typical case for my patients with MS, okay? So I tell you, pay attention. This is a 58-year-old gentleman. He's had MS for a long time. He has secondary progressive disease. And they had their usual Sunday night dinner with the family. And people thought, God, Dad's a little not quite right. You know, he's a little, it's Yiddish, famished. Famished, okay, which means you're a little mixed up, okay? So they blew it off. They said, well, it's the end of the day. He did a lot today. We were out. We shopped. So Dad's just tired. That's why he's a little confused. No problem. He'll go to bed early. He'll be okay. The next morning, he doesn't come down for breakfast. People start to investigate. He's found in his bed, and they're having a hard time waking him up. And his speech is like mumbled, incoherent. Everybody gets scared. Paramedics are summoned. And when they get there, this guy's blood pressure is in the toilet. It's low. It's low. And he has normally a normal blood pressure. He's actually on blood pressure medicine for hypertension. He hasn't taken it this morning because he hasn't woken up and gotten out of bed. So it's not that he overdosed on blood pressure medicine. His blood pressure is too low. His temperature is normal. Now, I say normal, and I want to put quotes in it. What kind of temperatures do patients with MS generally run? A lot of patients with long-standing MS tend to have low temperatures as their normal, 95, 96, 96.5. Do paramedics know this? Do people in the ER know this? Do they recognize when patients with MS have fever? So his temperature is 99 and his normal is 96. He has a fever. But the paramedics go, oh, well, his temperature is normal. Speaks against infection, right? They think. So what do? They do what they do for everybody, start the IV fluids at the bedside, and bring the patient to the emergency room. In the ER, he's stuporous. Stuporous means you shake him and he says, and then he goes to sleep again. But then he progresses. In the first hour in the emergency room, he goes from stuporous to totally unresponsive. Okay, we call that coma. Okay, so now the patient's in a coma. His blood pressure has catapulted down lower, and so ER's on board. They know what to do about that. Fluid resuscitation is increased, and medications called pressors are started to boost his blood pressure up. Okay? They know how to do acute management of life-threatening illness. This is life-threatening illness. They send off the first bloods, and what has he got? He's got a big white count in his bloodstream. So what does that suggest? Infection. Infection. The urinalysis, which they get, also shows many white blood cells and many bacteria, suggesting bladder infection, okay? Does bladder infection generally put my MS patients into a coma? No. So what has to happen to get coma from a bladder infection? Well, it has to affect the brain. How does it affect the brain? Where do the bacteria have to go first? Bloodstream. Bloodstream. So if you have a bladder infection and the bacteria overwhelm and get into the bloodstream, you begin to get toxic effects of bacteria in your bloodstream. And the toxins from the bacteria lower your blood pressure and intoxicate your brain sometimes. And we call that, in the face of a bladder infection, we call that urosepsis. Urosepsis. Is urinary tract infection the only thing that can do that? No. You can get a pneumonia, and if you let it go, like certain political figures, this is people are gonna have to look at the date and the time on this on the website to know who I was talking about, and then they'll laugh. If you neglect your pneumonia and it goes into your bloodstream, you can also die of sepsis from pneumonia. Any bacterial infection that invades the bloodstream can cause a critical illness called sepsis. And there are ways that the ER and the ICU knows how to deal with a septic crisis, okay? And they have to maintain the blood pressure, get fluids in you, and get you quickly on antibiotics. So this guy is unresponsive, maybe just from his sepsis. So the history is reviewed with the family. He's had 20 years of MS, he's on Rebif, he's doing well with his disease-modifying drug, he happens to take baclofen and tizanidine, and they check the bottles, he didn't overdose. He takes Ampura to help him with walking. He's been on it for 5 years. He likes his Ampura. It works really well for him. He's got a bum bladder. So he takes oxybutynin, which helps him hold his urinary urgency. He works full time. He's cognitively normal. He's never had confusion before. Okay? So this is a catastrophic illness for this gentleman. So he gets transferred to the ICU. He's placed on broad spectrum antibiotics, because until you know what the bug is, they cover you for all the bugs, right? Fluids and pressors are continued. They do a CAT scan. They always do a CAT scan because you're in coma. That was actually done from the emergency room on his way up to the ICU. What does it show? It shows low intensity, sort of blackish areas around the fluid spaces. What do you think those are? MS plaques. So MS plaques look dark on CAT scan when they've been around for 20 years. CAT scan when you just started your MS is negative, it's normal. You can't see plaques on CAT scans in early disease at all. But later, when they've been there a long time, particularly if they've turned into holes, then you can image them on a CAT scan. What does the emergency room always read them as? And somebody who they don't know what they're doing, they say, oh, he's got old strokes. No, he doesn't have old strokes. He's got old MS plaques. So more lab studies are done in the ICU. The white count stays very high in the blood for a while. The blood cultures turn positive for a gram-negative rod-type bacteria. What's the most common bacteria that people get in their bladder? E. coli. E. coli comes from stool. That's what crawls up into your bladder and gives you a bladder infection, right? So he's got E. coli in the blood. So we know it came from his bladder. Now they've identified the bug, they can narrow the antibiotics they're going to give him. His liver function is normal. His kidney function is way off because he's infected in the bladder because he normally doesn't have a bladder that empties properly, and it turns out he's been having some back pressure. His kidney function has been declining probably over a while. Somebody looks back in the last labs and they discover, oh, he had normal kidneys 3 years ago. Then his creatinine crawled up a little bit. His GFR, that's the measurement for kidney, got a little bit down. This last year it was a little bit down from there. Now it's really down, way down, way down. Why is that bad in this setting? Well, first of all, he got urosepsis from his bad bladder. But what's the other problem here? What did he get toxic with because his kidneys don't work? Ampura becomes toxic if you don't have normal kidney function. So, what's wrong with this gentleman? He has urosepsis, but guess what? We're going to do a diagnostic test that he hasn't had done yet, and he needs done right away. What test is that? He's comatose. We want to know why he's comatose. What might help us? I want an EEG. What's it going to show? Seizures. What kind of seizures? Status epilepticus. This guy is in status. He's in status. He's not shaking, you go. He's not jerking. You didn't tell me he was jerking. There's something called aconvulsive status epilepticus. It's dirty pool, I didn't teach you that. But I did teach you everything else. Aconvulsive status means you're having seizures continuously from the brain, generalized, both sides of the brain, but you're not shaking. You're not shaking. And that can happen when people are toxic and very sick. So they got the EG, the guy's in status epilepticus, they load him up with anti-seizure medicine, and gradually he does wake up. But not until he's been on a ventilator for a few days, because in order to give him all the seizure medicine, as sick as he is, those medicines would impair his consciousness, his breathing, lower his blood pressure further. So a guy like this ends up intubated in the unit, on a ventilator, with continuous antibiotics IV, with seizure medicines at very high doses to stop it, with continuous EEG monitoring, and that's what happens. And then he gets better. And so when the family says, well, he never really wanted life support, I say, no, 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 no. This is not that kind of life support. This is, we're going to fix his infection life support, okay? So you have to really have frank discussions, because the most likely thing is he's going to come out of this. And this was a highly functional, normal person with MS. So what are the lessons here for his future management? Does he really have an ongoing seizure disorder? Probably not. This is a toxic form of seizures, right? Will he never be able to take Ampura again? Well, the insurance company will say he can never take it again, but that's not really right. If we can restore his kidney function to normal, he could take Ampura again. How are we going to make sure his kidney function stays normal? He's going to go see Mary Kay on a regular basis and make sure that he's emptying his bladder, that the oxybutynin is not putting him into retention, that his renal function is not getting bad again. Believe it or not, I've had patients to whom this has happened more than once. Okay? So, critical illness can be avoided if you take care of the basic overall health of the individual with MS. Okay, with that, I'm going to stop. Are sharp pains in the side of the head a seizure? Usually not. They're usually ice pick migraines, go see Amy, or they're in neuralgia, go see your neurologist. Okay. Oh, is deja vu always related to having a seizure? Absolutely not. 99.9% of the time, when any of us gets deja vu, we get deja vu. It's a phenomenon that happens to people. It's probably something in the brain, but it's not usually a seizure. But if you keep getting it over and over again, then it might be. But I had one lady who got deja vu as a seizure, and she said it was almost a pleasant sensation, and she would always get it in the mornings at work. And one day she got her deja vu, and then she wet herself. And she said, oh, this is not normal, this is not pleasant, this is wrong. And she had partial seizures. Okay, but in general, any one of us can get deja vu now and then, and it is a normal phenomenon. When deja vu does come from seizure disorder, it usually comes out of the temporal lobes. There's certain parts of the brain that are more prone to generating epilepsy. The temporal lobe is one of those locations. This is a different symptom. Somebody has a spot on their back that itches, it itches, it itches, and yet there's nothing to see there. Could that be a seizure? And in fact, I would suggest that focal itching is a very typical MS symptom, not a seizure, okay? I don't think I've ever seen a patient with epilepsy whose symptom was itching. And itching will, again, probably go on and off all day long possibly, but it's odd. People with MS can just have a patch that itches or a spot that itches, and really that's neuritic pain. It's a form of pain in MS. Okay. Husband was epileptic as a child. His seizures always happened in the first few hours of sleep. That's not unusual. Physical exertion is sometimes a trigger. So there are a lot of things that really lower your seizure threshold that make it easier to seize. So sleep deprivation makes it easier to seize. If you happen to have epilepsy already, being stressed sometimes does it. Alcohol will do it. For some people, marijuana will do it. Anything that synchronizes brain activity can do it. So there are some people also, if they highly exert themselves, they're more likely to seize. You have to be on a good seizure medicine so that none of your triggers will in fact cause a seizure. So effective treatment of people means that you've actually protected them from seizing, even in the face of typical triggers. Because who can avoid sleep deprivation every now and then? Some of us more often than others. All right. Seizures are usually violent during sleep, chattering. They last 1 to 2 minutes. That sounds like a grand mal. That could be a grand mal. Does not wake up after. That's called a post-ictal state. So people who seize in their sleep, sometimes they don't wake up enough to even see that they're confused and they fall back to sleep. But if they're doing that repeatedly during the night, time to call the paramedics. Very sore in the morning. So some people who have had grand mal in sleep, they know they've broken through with the seizure because they wake up in the morning and they're sore all over. That's how they know they've had it. All right. I think somebody's asking me about corticobasal ganglion degeneration and seizure, and I don't have immediate information. Whoever you are, come to me about that. Do simple seizures, if you have a partial seizure, does it always lead to grand mal? No. I've had people who've had a simple seizure disorder for decades, and they never ever went into a grand mal. So one does not necessarily demand the other. Is MS and epilepsy directly related, like in a genetic way? No. Does epilepsy run in families? Yes. Do autoimmune disease run in families? Yes. So you could be a person with MS and have relatives with MS that also have epilepsy. You could have epilepsy. You could have both as genetic syndromes, but they are separate disorders, not connected. Okay, and the other autoimmune diseases, this person says, husband's sister has Crohn's, an 8-year-old nephew has fevers and may have something autoimmune. Autoimmune diseases do run in the families of people with MS. But again, that's not epilepsy. Okay, guys, I want to let you move on and have your break.